Switching Mycobacteria, but fortunately back to MAC. And on a topic that I think is clear from all the questions today is so incredibly important. How are we ever going to set clinically relevant breakpoints based on all that we have learned, mainly from the Dallas team, about PK/PD? So, floor is yours. Thank you.
Thank you, Dr. Van Ingen. So, I have no conflicts to disclose. And this is a brief outline of my talk. I'll just talk very briefly of what's the distribution of NTMs, what are the current treatment guidelines for pulmonary MAC, what's the efficacy of current regimens, what are the limitations of current therapy, but mostly I'm going to focus on how can we identify susceptibility breakpoints using a PK/PD approach and Monte Carlo simulations that are more predictive of how the patient is likely to do. This slide here just shows the distribution of different non-tuberculous mycobacteria isolated from pulmonary samples across the globe. The panel A shows the figures for MAC, since I'm talking about MAC, and you can see it's present really all across the globe. It's not a problem or clinical condition limited to just one particular country or continent. It's present all across. And I think some of the areas that you see missing is not because it's not there. It's just because I feel we haven't looked. And this is another distribution of the isolates amongst all the respiratory isolates that were recovered. MAC comprised or was isolated most commonly, ranging between 30 to 70%. And these are some of the treatment guidelines, and the other speakers have already gone over this, but I'll just highlight that macrolides, azithromycin, and clarithromycin, along with ethambutol, form the cornerstone of current treatment regimens, and then rifampicins and aminoglycosides can be added based on the nature of the disease, the severity of the disease. How effective are our current regimens? And this is a slide that my colleague Dr. Pasipanogia had shown earlier, so I won't go over it, but basically we did this meta-analysis in which patients with HIV and cystic fibrosis were excluded. However, those with pulmonary MAC were included, and of the 21 studies that we include, if you look at the sputum conversion rates, you can see here for the different time points at 6 months, end of treatment, and on follow-up, the key point here you will notice that the response rates for conversion are very low. The pooled incidence rate ratio of sustained sputum conversion was only 0.54 for macrolide-containing regimens, essentially, which means 1 out of 2 patients failed to convert their sputum, and that for macrolide-free regimens was even lower. There are several limitations to current treatment. I'm not going to go over all of them, but what is of most interest and what is of most interest to clinicians is why is there such a poor correlation between in vitro susceptibility testing and clinical response? Of all the agents that are currently in use, it's only macrolides for which we do susceptibility testing and is shown to have some correlation between response and the susceptibility results. So what I'm going to present is how we can try to improve this correlation for other drugs or other agents that can be tested for MAC using a PK/PD approach and using Monte Carlo simulations to give a better predictive MIC susceptibility breakpoint. So you have seen this slide, I think more than one time during this presentation and this workshop, but what I would like to point out is the hollow fiber model is an in vitro PK/PD model, and it's a dynamic model, as Beatrice has pointed out, and it's a 2-compartment model where this is your central compartment, which conceptually represents your circulatory system, and the peripheral compartment, or the hollow fiber cartridge, represents the site of infection. And what we do is we put THP1 macrophages that are infected with MAC into in this compartment, and then we start therapy, which is delivered by computerized syringe pumps to mimic concentration time profiles, pulmonary concentration time profiles seen in patients, and then assess the microbial response to therapy. The response is modeled using an inhibitory sigmoid Emax curve, which gives you what is the PK/PD parameter that drives efficacy or is linked to kill, and then what is actually the target exposure. And we have looked at several drugs in the hollow fiber model and identified their PK/PD exposures. We've looked at azithromycin, we've looked at ethambutol, we've looked at some other agents like moxifloxacin, some newer agents, especially the oxazolidinones, linezolid, tadazolid, and we've derived optimal exposures and PK/PD parameters linked to efficacy for this drug in the model. I'm not going to focus on what was the response or how well they did in the talk. What I'm going to talk about is how we integrate these target exposures derived from this dynamic model using Monte Carlo simulations to predict MICs that are more indicative of clinical response. So when you use the target-derived exposures, you integrate it with pharmacokinetic parameter estimates such as clearance, volume of distribution, what is the penetration ratio of the drug, what is the protein binding of the drug. These are all input into a program called Addict, which basically then gives you what is the proportion of patients, of 10,000 virtual patients, who are likely to exceed or achieve this target exposure. The highest MIC that will allow the achievement of this optimal or target exposure in more than 90% of patients is then chosen as the susceptibility breakpoint. And then based on CLSI definitions, the clinical concentration to indicate drug resistance will be set to 1 tube dilution higher than what your susceptibility breakpoint is. I'm going to give you an example here of azithromycin. So we've already done the experiment in the hollow fiber. We've derived the optimal exposure. And here you can see, so if your isolate has an MIC of 0.5, what is the proportion of patients that is likely to achieve this target exposure? It's good, it's more than 90%. But as your MIC increases, your probability to attain that optimal exposure starts to decline. And you can see here below in blue line is the MIC distribution of clinical isolates for azithromycin. So basically, if you have your susceptibility breakpoint at 1 milligram per liter, your critical concentration to indicate resistance would be 2 milligram per liter. This is based on the PK/PD approach. However, we know this current susceptibility breakpoint to indicate resistance for azithromycin is 256 milligram per liter. So that's a 128-fold difference, 128-fold lower resistance or breakpoint for azithromycin. And that may be one reason is that the misclassification of isolates which are currently deemed to be susceptible are actually resistant, and may be a reason for the poor response that you see with current regimens. This next graph here is just an example. If you were to lower your target exposure, so say instead of achieving the maximal exposure, you just achieve 20% of your maximal kill, how far can it get you along the MIC? And it's not very far. You can see at MICs of 4 milligram per liter, you will not even achieve a 20% kill of your maximal kill. The next slide is just another representation of your AUC to MIC exposure of azithromycin for the standard dose of 500 milligram and 1 gram here. And you can see until the time the drug concentration or exposure stays above the MIC, you'll see some effect of the drug. But as soon as that exposure or concentration falls below the MIC, you're not going to see any kill or response. And essentially, that isolate beyond or above or that MIC is essentially resistant to the drug. This is also an example with ethambutol. We have again derived the exposures in the hollow fiber, and you can see if you were to consider the 15 milligram per kilogram dose, you can achieve the target exposures at lower MICs of 0.5, but as you go higher, the target attainment falls. If you were to go a little higher with the dose, it gets you a little farther, but again, if you look at the MIC distribution, a lot of your isolates are still not going to be killed by the doses that you're recommending, so the doses that are in use. So your susceptibility breakpoint is essentially much lower. It would be 0.5 milligram per liter for your 15 milligram per kilogram dose, and 1 milligram per liter for your 25 milligram per kilogram dose. The next example is of moxifloxacin. We did a similar exercise with moxifloxacin, and you can see to achieve the optimal or EC80 exposure with your 400 milligram dose, your susceptibility is, if I can see correctly here, it's a little small to see, but your susceptibility breakpoint would be 0.125, and your critical concentration would be 0.25 milligram per liter. And if you were to lower the exposure here, say you wanted to achieve an exposure that would give you 1 log per kill every week, it gets you a little further out, but not a whole lot. And this is the MIC distribution for moxifloxacin isolates, and you can see with the proposed susceptibility breakpoints derived by this PKPD approach of 0.25 milligram per liter, most of your isolates are way beyond that distribution. This is of the example for one of the newer drugs that we looked at, Linezolid, and you can see if you look at the standard dose of 1,200 milligram per day, your target attainment probability starts to fall above MICs of 8 milligram per liter. So essentially 8 milligram per liter is your susceptibility breakpoint, and your critical concentration to describe resistance would be 16 milligram per liter. Again, this is much lower than the current set breakpoint of 32 milligram per liter, which just means that most of your isolates are not going to be susceptible. This bottom graph here is a summation or a cumulative fraction response of all the target attainment probabilities for the different doses across the MIC distribution, and you can see with your dose of 1,200 milligram per day, you are achieving the optimal targets in only 70% of patients. However, if you were to use a higher dose of 1,800 milligram per day, you could achieve those targets, but again, that's a high dose. We know it's associated with toxicity, so if you can tolerate, that's fine, but essentially your standard dose or recommended dose only gets you a 70% target attainment. The last example I'm going to show is of the congener to Linezolid, and by far, this is the best response we've seen in the hollow fiber with any drug against pulmonary MAC. And the panel on the top is the target attainment probabilities for bactericidal effect or 1 log, for bacteriostasis. That means the exposure required to hold bacterial burden constant to your starting inoculum. The second one is for bactericidal effect to give you 1 log kill, and the bottom is to give you a 2 log kill. And you can see this is an MIC distribution obtained from the FDA docket, which goes up to 2 milligram per liter, and you can see your standard dose of 200 milligrams per day can achieve the target for bacteriostasis up to, all the way to 4 milligram per liter or higher MICs. For your 1 log kill, your proposed susceptibility breakpoint will be 1 milligram per liter, where you get a good target attainment of more than 90%. But for higher MICs, you will need to use a higher dose of 400 milligram per day. But by far, the best drug with best response that we have seen in the hollow fiber and in the simulations for susceptibilities. So in conclusion, we know prevalence of MAC is on the rise everywhere. Therapy outcomes with current regimens are at best modest. The hollow fiber model is a preclinical in vitro PKPD model, which enables the determination of optimal or target exposures for MAC, for anti-MAC agents, and Monte Carlo simulations based on target exposures derived from the hollow fiber, along with the MIC distribution of clinical isolates to determine target attainment probability, will allow the identification of susceptibility breakpoints that are more predictive of response to therapy. This is all the team that I work with and are very important in all the work that I have done. Dr. Gumbo here leads our group in Dallas. Some of my colleagues, Shashi was here speaking earlier, Jadam speaking here earlier. Jadam does a lot of the modeling work, Shashi does a lot of the hollow fiber work, and Gesham here also does a lot of the modeling work. With that, I'd like to thank you all for your attention, and I will take any questions or comments.
Well, we have time for comments, and you're up first.
Yeah, your Linezolid work was very interesting. I was just wondering, is there cross-resistance with Linezolid, or are there some mycobacteria that would be susceptible to Linezolid and not to Linezolid?
So I didn't...
So his question was, is it a class effect? Are there some mycobacteria that would be resistant to Linezolid but susceptible to Linezolid?
You know, it is possible, yes. I think there will be isolates that are resistant to Linezolid but susceptible to Linezolid, but that based on the fact that Linezolid is a drug that we know is concentrated more in macrophages, and also because the MIC distribution, the range of MIC distribution is much lower. So, you know, the higher end of the spectrum for Linezolid MIC distribution goes only to 2 milligram per liter. So there's much more room to play. You know, you have a ceiling as to how much dose you can give, which is bounded on the bottom by your MIC distribution. So the wider the range you have, the more room you have to achieve your kill, which in the case of Linezolid is much narrower. So I think, yes, there may be isolates that are resistant to Linezolid, but will probably do better with Linezolid.
Yeah, and to add to that, so one of the advantages, the pharmacokinetic advantage of Linezolid over Linezolid, in addition to safety issues, which I think even for Linezolid are still to be determined in terms of long, administering it for many months. But one of its advantages is you get a 40-fold entry into epithelial lining fluid and the lung and alveolar macrophages. So it has that extra penetration advantage, so you can achieve more with it at current standard doses. But I actually wanted to ask Deviani to elaborate further, which it wasn't the focus of her thought, of her talk here, but the kill rates achieved, and Jaco alluded to it, the kill rates achieved in MAC with mycobacteria, with Linezolid versus Linezolid were actually very different. Linezolid was highly effective. Linezolid was even more. I mean, so you get several logs, and I wanted you to comment about.
So when we do the hollow fiber experiments, we quantify the kill of each of these agents, and what we saw with Linezolid was the maximal kill we could get was 1 log below stasis. So if you start with a bacterial burden of, say, 5 log, a maximal kill of Linezolid will get your bacterial burden down to 4 log. But what we saw with Linezolid was you get even further or a deeper kill. So if you were to start at 5 log, the kill that you see with Linezolid is 2 log below stasis. So that's a significant difference. And as Dr. Gumbo pointed out, it may be related to that it penetrates the macrophages very well. The MIC distribution is good, but on all fronts, Linezolid definitely did much better than Linezolid.
And to put that into context, our best drug, right, azithromycin, alone, and is the cornerstone, right, will kill below a log on its own. So if you sort of just wanted to compare the killing capacity, there is something there.
I have a question about the MIC distribution. So often I try to do the same kind of exercise of gathering reports of various MICs, but I'm really only able often to just establish the range. The actual frequency distribution I find very difficult to collect that data. So how many patients, or how confident are you that these MIC distributions that you're using are actually representative of the patient population that you're trying to target?
That's a very good question. The MIC distribution can change from geographic areas, between geographic areas, but the MIC distributions that we looked at typically had isolates that are about 100, 200 plus. For the Moxifloxacin, the distribution was for about 102 isolates. So the more number of isolates that you have in your distribution, the more robust is your prediction and your simulation. But yes, your MIC distribution can vary between geographic areas and can lead to different susceptibility breakpoints for different areas. But the way to do it is to use a large enough MIC distribution. You could probably integrate MIC distributions from different geographic areas into your simulations to give a more global MIC susceptibility breakpoint.
So there will be there, if you look in FDA dockets and things like that, but sometimes there isn't. So for some Mycobacterium abscesses studies, JECO ended up having them do MICs in clinical isolates in the Netherlands. So sometimes the information is there, but the larger your number, the better, right? You just get a much more robust. And in some instances, you get a lot of MIC data. When we're looking at Mycobacterium tuberculosis, for example, we had hundreds from Germany, 600 from China, or something like that. It depends. And we also internally, for new drugs we're testing, look at our panel, our internal library, and do those MIC distributions. But it's a real question, and a lot of it is not published in the form you can use it. They just say, oh, the MIC 90 is this. So, but a lot of the time when you go back to the original authors, which we have, you will be very surprised by how well people actually share the data. They'll send you the spreadsheet.
And there's one small thing to add to that, and that is that MICs are not just determined by the bug, but sadly also by the platform that you use. And that's a very tricky thing to do. If you look at MIC distributions, that's nice, but you should have a look at what platform did the investigators use to come to their MICs, because MICs are largely determined by whether you do it on solid media or in broth, whether you have buffers in there that keep pH constant, because a lot of antimicrobials are affected by pH, and that could be by higher or lower pH. So that's always an important consideration. Yeah, you have to get back to the raw data, and well, we do these tests, I don't know, 800-900 times per year. So we have thousands of isolates with MIC data from a single platform, and yet you cannot easily compare them to data from other settings because of differences determined by different strains in different areas, but also different platforms being used. And that's also something to always consider. I think there's one more. There's one more question.
No, I was just going to comment on the question that Beatrice asked on lung damage in patients. This we have looked at this based on data from Tarrant County in the United States, and where we looked at patients with pulmonary tuberculosis. These were published, and in patients with non-Mycobacterium tuberculosis, part of that data we presented at ICAC, where we looked at lung damage, looking at x-rays and lung function tests, and we followed them up for about 5 years, and we noted that those patients, even those that were 3 times as likely to die within the 3 years using standard therapy. And then we did some simulations in patients with tuberculosis where we were able to show that if you were going to intervene using a thought experiment, using a Bayesian adaptive dosing of standard therapy, you would actually lower the mortality rates and even the failure rates by multiple folds. So these are some of the things we are starting to look at on whether we can actually intervene iteratively to give some of those thresholds that Dr. Deshpande has been talking about. Thank you.
Yes, there's one more question, and well, we have time for that.
Thank you very much. Nice presentation. I have a simple question. I hope to get the information from you. Generally, in case of the murine TB model, we have a gold standard strain for the infection study. For example, H37RV or the other kind of the representative virulent strain we have. But in case of the setup for the simulation ulcer model of the Mycobacterium infection, we sometimes in troubles. What kind of the standard strain should we use? And surely we selected several strains, but if you have enough information about the most recommendable strain of the Mycobacterium for the simulation ulcer model, do you understand my meaning? Question? Because in relation to his question, Ali.
I'm sorry, I think we couldn't hear the question here very well. If we can meet after this, and I will be happy to answer your question. But we had difficulty really hearing the question. Yeah.
As you know, the very broad range of the virulency or drug susceptibility Mycobacterium strain they have. And so what kind of the strain we should utilize for the setting the in vitro or in vivo simulation assay model? We don't have gold standard strain, we don't have. And so if you have some of the specified Mycobacterium strain or the recommendable Mycobacterium strain, I would like to know about it. You understand?
Yes, it's actually a very interesting question, and you're absolutely right that strains have different levels of virulence, particularly within Mycobacterium avium. And yes, the question is, is a model using a single isolate a good representation? I mean, the isolates that cause disease in your patients might indeed be different from the isolates that we all tend to use in experiments because they are reference isolates. And I think that point was made by Beatrice Ferro as well, that we need to extend these analyses into clinical isolates to capture some of that difference in virulence. The other problem that I personally have with that is that there's no one who can tell me what virulence is and how you can measure it on a scale. And that is something that I think is always a little problematic. But you're absolutely right that these types of simulations need to be repeated in larger sets of isolates with different, hopefully, levels of virulence if you can measure them as such. So it's a very, very good point.
Thank you very much.
And you're right. I think these are what we usually do, what we have done with tuberculosis is you start off with these simulations, you get an idea, but you still need to go to, you have to prove it, that in the clinic, these breakpoints determine who will respond and who won't respond. So it's a starting point. And you then have to go to patients who have actual virulent isolates, but it's a starting point to try and separate who will respond and who won't. You are absolutely right. The virulence, the disease extent, as Jaco pointed out, all those factor into who will respond. But this is just a starting point.
Thank you very much.
Thank you. Well, with that, thanks again for a brilliant talk and a very, very clear summary. And with that, we close this session. I would like to remind you all that it is possible to give your feedback to the organization on this session and on the conference in general. Please do it. That might mean that we have more time next year, more talks on NTM next year. You should all vote for that. I count on you. So please do that, and thanks again for coming up to this session on NTM. I hope you've learned a lot and at least had a great time. So thanks. Well, the next talk actually switches Mycobacterium again into Mycobacterium cansaceae. And interestingly enough, in the NTM community, everyone always laughs at Mycobacterium cancericii because, oh, it's so easy to treat. Yes, if you give 3 to 4 drugs for almost 2 years. And I really hope that the next speaker, Dr. Shashikant Srivastava, will finally tell us how we can shorten that treatment duration and use drugs that are as effective as possible. So the floor is yours. I hope you can tell us.
Thanks, Dr. Vanyan, for the introduction. So I don't have any conflict of interest to declare.
Okay, please speak into the microphone.
Oh, sorry. So today I'm going to talk about Mycobacterium cancericii, and how much importance we give to Mycobacterium cancericii is illustrated by the fact that in the introduction of this session, it was missing from the slide. So the chronic pulmonary infection caused by Mycobacterium cancericii is a problem, and then the disease presentation very much resembles with the Mycobacterium tuberculosis. And this is the second, what is happening? This is the second most common NTM infection in the AIDS patient, only to be surpassed by the Mycobacterium avium. And then the current treatment guidelines says that a combination of isoniazid, rifampin, and ethambutol daily for up to 18 months and up to 12 months after the sputum conversion. And there are studies which show that fluoroquinolones, they are effective against Mycobacterium cancericii. So in our experience also in my lab, we find that in other Mycobacterium, Moxifloxacin is very effective. It shows the efficacy against Mycobacterium tuberculosis, Mycobacterium avium, and just Beatrice showed that against M. abscesses, Moxifloxacin does not have any efficacy. But anyways, we went ahead and we started testing Moxifloxacin against Mycobacterium cancericii. So what we did, we first did the MIC and dose response studies at static concentration for both intracellular and extracellular M. cancericii. So these are the concentration ranges of Moxifloxacin we tested in each of the experiment. And in the intracellular experiment, we used the human-derived THP1 monocytes. We infected them with M. cancericii and then did the experiment. For the MIC experiment, we used the risazurin colorimetric assay, where we took a portion of the cultures set up for the extracellular study and then transferred to a 24-well plate, added risazurin to get a final concentration of 0.001%, incubated the plates for further 24 hours, and then looked for the color change from blue to pink to determine the MIC. So here, as you can see in this slide here, the color, these are the non-treated controls, and then the increasing concentration of the Moxifloxacin. And then the inhibition we see at 0.06 mg per liter, which was determined as the Moxifloxacin MIC for M. cancericii. And then this graph here shows the Moxifloxacin dose response at the static concentration for both extracellular and intracellular bacteria. And you can see the Moxifloxacin showed a very good Emax of close to 8 log against both the populations. However, the EC50 concentration against the extracellular population was slightly better than the intracellular. Then next we developed a hollow fiber model system for intracellular hollow fiber model for M. cancericii. I'm not going to get into the details, but just talk about the schematics of the hollow fiber, and this is how it looks when you set up in the lab. So this is a system of the tubes and bottles and pumps. So this is a bit complicated system. And using this intracellular hollow fiber model, we did Moxifloxacin dose response as a monotherapy, and we treated the systems with a human equivalent Moxifloxacin doses of 25, 50, 100, 200, up to 800 milligrams per day. In addition, we used 2 more additional arms where we treated the 200 milligram and 400 milligram combined with the efflux pump inhibitor reserpine at a final concentration of 10 mg per liter to see if there is any efflux pump mediated tolerance to Moxifloxacin. And all the kill slows with each of the doses were compared with the standard combination regimen. The systems were sampled on day 0, 3, 7, 10 to enumeration of the total as well as the drug resistant subpopulation if it emerges. And then finally, we did the Monte Carlo simulation to come up with a dose, optimal dose to treat M. cancericii and what would be the susceptibility breakpoint for that given dose. So these are the concentration time profile of the different Moxifloxacin doses as we did in the hollow fiber system. using the one compartment model, and this figure here shows the model predicted versus the observed concentration with the R square as 0.99, shows that there was a minimal bias. So these are the results for the experiment we did. So first, here are the results of the standard 3-drug combination. The non-treated controls, we started the experiment around 6 log of the bacteria, grew to up to 11 log in 14 days of the study. The 3-drug combination initially showed a good kill of close to 1.5 log for the first 3 days, and then it becomes flat. So it lost its efficacy very quickly. Whereas if you look at the moxifloxacin monotherapy experiment, the higher exposure of moxifloxacin, which was an AUC of 64, sterilized the intracellular MCAS in just 7 days. And if you look at this AUC of 12.9, when you combine with the efflux pump inhibitor, it also sterilized the system in 7 days. So that means there was some efflux pump mediated tolerance to moxifloxacin, which can be overcome by the higher doses of moxifloxacin. And you can also see the kill rate of the standard combination was only 0.08 log 10 CFU per mil, whereas the moxifloxacin highest dose killed at a rate of 0.8 log 10 CFU per mil per day, which is very high and quite impressive. And this figure here shows the relationship between the bacterial burden and the exposure, and based on this, we calculated the EC80 or optimal exposure of moxifloxacin for treatment of MCAS is a ratio of AUC to MIC of 317. And we know moxifloxacin has some protein binding activities, and even if you assume 50% protein binding, the EC80 exposure will come as 158. The most interesting finding was that there was no emergence to any of the moxifloxacin monotherapy exposure in this 14-day experiment. So and then we did the Monte Carlo simulations of the 10,000 patients to see the moxifloxacin dose, which is going to achieve that EC80 exposure. So here are we did the simulation for 200, 400, 600, and 800 milligram doses of moxifloxacin daily. The 200 mg daily dose achieved the cumulative fraction of response in less than 30% patient when you consider the MIC distribution. 400 milligrams or the standard dose failed to achieve the CFR in more than 30% patients. The 600 mg dose did slightly better than the standard dose, but still the performance was below the 90% threshold. The 800 milligram dose did the best, and it achieved the CFR of in more than 90% of the patient. And based on this simulation, we can see the susceptibility breakpoint for this 800 milligram daily dose should be 0.25 mg per liter. So in conclusion, we developed a hollow fiber model of intracellular MCAS, which can be used to do the monotherapy or combination therapy for moxifloxacin or for MCAS. And we showed that moxifloxacin has a very good efficacy against the intracellular MCAS, and then the efficacy is better than the 3-drug combination of the current regimen. And we recommend a moxifloxacin dose of 800 milligram, which is shown to be tolerable in this particular reference, and there are other studies which show that 800 milligram dose is safely tolerable in the patients. And this is my team at Baylor, and I would like to thank to Baylor and then NIH for the fundings to do these studies and questions.
Well, thank you very much, and very, very clear talk, and very well in time. So we absolutely have time for questions, and I think there are already 2 people moving forward. So, please.
Thank you for your study and presentation. My question is about the long-term results. As far as I see here, you have 14-day results.
Yes.
You don't have the full course of treatment, then the relapse data. So without that, your first conclusion, you cannot tell it for Mycobacteria. For Mycobacteria, you should have a combination therapy, a full course of treatment, then you should have a relapse study also. Early bactericidal activity is only the part of the story, not the whole. Thank you.
Okay. So this is a good question. So we did the intracellular study, and as you see, there were 6 or 7 different doses, and then the highest dose killed the mycobacteria by 7 days. So even if you continue the study for a long time, if all the mycobacteria got killed, there is no point continuing the study. And the second question is that we are doing other drugs and other combinations, but this is just a proof of concept that we can develop the model and we can optimize the doses of the different drugs for Mycobacterium consistent.
Yeah, based on your interesting results, what would be your proposal for a trial? What would be the new regimen you would propose, including Moxi?
Yes, that's also a very good question. So we optimize the dose for Moxifloxacin, and we are also now continuing to do the experiment to develop, combine Moxifloxacin with other drugs to develop the combination regimen. So as we speak, our experiments are going on.
Yeah, I wanted to, so if you wanted to do a pragmatic, to the concerns of the question that was asked and your issue, a very pragmatic trial would be to add Moxifloxacin at 800 to the current regimen and see if we rapidly achieve. You know, that's one way, right? Exactly. So then the patients are not at risk, and then you see if you rapidly get that kill rate that was seen in there. Yeah. Yes.
There's a question from, I'm sorry, your name? From Jose Luis Zavala. It's about non-tuberculous mycobacteria. He wants to know if the structural damage that the lung can have because of non-tuberculous mycobacteria favors of not the establishment of other microorganisms like Pseudomonas putida and Aspergillus, and if with those other microorganisms there's synergism that complicates pathogenesis and treatment also.
I will leave this question for the clinicians to answer.
Yes, so this, Dr. Van Ingen would better answer this, but there's certainly, there is information of different microbial communities, especially in cystic fibrosis patients who gets these infections. And even though it's a mixed infection, each of the individual organisms, some of them do their own damage. Now, it's an interesting question. When you have a single bacteria, there is a community-wide effect, all right? It's a community, and one of the interesting questions, so is there real communication, is there community-wide between different bacterial species in doing damage? And I don't know what the answer is.
I think I allow myself to have one last question. I agree that we haven't looked into the role of other pathogens out there, but I can tell you from clinical practice, our patients who have invasive fungal infection and NTM disease at the same time, they all die very rapidly. They end up in our ICUs, respiratory insufficiency, death. So there is something going on in the interaction between those two. My question regarding Moxifloxacin is, you've, of course, used a monotherapy model, and now a big issue of inserting it into a regimen would be that you're likely combining it with rifampicin, which in turn will lead to a loss of exposure to Moxifloxacin. I mean, across studies, it's usually a 30% decrease in AUCs of Moxifloxacin. So do you think if we want to achieve that exposure that you've seen with 800 milligrams in patients who also receive rifampicin, would we need to dose like up to 1,000 to still get to the same level of exposures that you have used?
So we have not done the synergy or antagonism study so far. So we should, as Dr. Deshpande, I think she is going to talk about how to design the regimen. So we need to do the synergy or antagonism study between rifampicin and Moxifloxacin, or whatever two drugs you are going to mix it, and then come up with the optimal exposure combination, and then which is not showing the antagonism, and take it further to develop the combination regimens. I think that is the way to go for it.
Okay, wonderful. Well, again, thank you very much. Great talk, very interesting, and very interesting breakpoint as well.
Thank you much.
Thank you.
But I wanted to introduce Dr. Beatrice Ferro from Colombia, from Cali, who has been working, starting in a PhD work on looking at new treatments for Mycobacterium abscesses.
Thank you, Dr. Gumbom. Hi. Can you hear me? No? Okay, I will try. Okay, so my talk is about how to analyze what we have running now for the treatment of Mycobacterium abscessus. This work was part of my PhD, and I did it in Radboud UMC in the Netherlands, also in Dallas at Baylor Research Institute. I have no conflict of interest to disclose. So Mycobacterium abscessus pulmonary disease is practically not easy to cure, not easy to treat right now based on the antibiotic treatment that we have available. As you can see, or maybe you have heard before, there are several regimens based on the subspecies that is infecting the patient. But all the regimens are based on amikacin, clarithromycin, depending on the subspecies, and a beta-lactam like cefoxitin or imipenem. For the initial part of the treatment. Then the treatment can be followed by oral antibiotics, but anyhow, as Jordan mentioned in the first presentation, the outcome of this treatment is really, really poor. Very often, at least half of the patients either fail, relapse, or even die using this. So the conclusion that Jordan mentioned, and somehow that Jaco just mentioned for MAC, is that a new regimen is needed also for Mycobacterium abscessus. The evidence that we have now for the regimen that we are using is very limited, as it is the clinical evidence. So there is no pharmacokinetic or pharmacodynamic foundation or strong foundation for this treatment. Perhaps you have worked or heard before about the minimum inhibitory concentration. Those are the methodologies that are available, also synergy testing, time kill assays. But we detected a need for a preclinical in vitro dynamic model that can be used as a tractable model to study the current and future treatment regimens for M. abscessus. That's why we developed the studies I'm going to show you. In the time kill assays, basically what we have is Mycobacterium abscessus in bottles, and those bacteria are exposed to different but fixed concentrations of any antibiotics that you want to test. And we look over the time how many bacteria die using this treatment. In the hollow fiber model, on the other hand, and this is the model that we developed for Mycobacterium pulmonary disease, Mycobacterium abscessus pulmonary disease, we have a dynamic concentration of all the antibiotics that we are testing. And how dynamic, as it happens in human patients, when you receive a treatment, IV or oral, of any antibiotic, the concentration is not static. It varies from time to time. So the hollow fiber model mimics that variation. In the cartridge that you see over there, I don't know where the pointer is, sorry. Here, in this cartridge, there are several or thousands of hollow fibers inside. So when you pump the medium and the antibiotic through those capillaries, the antibiotic can diffuse from the capillary itself, that is like the blood, into the peripheral part or peripheral compartment that will mimic like the infection site, in this case the lung. As you can see here, the green part. So the antibiotic will reach the place where bacteria are, and that will be used to mimic the different concentrations that are obtained when a patient is treated. So using these two methodologies, we came up with at least four conclusions that we can share today. First, something that was already known based on clinical outcomes is that the efficacy of most currently recommended antibiotics to treat Mycobacterium abscessus pulmonary disease is low. How is that possible? Well, in the time kill assays we conducted for amikacin, you can see that the effect was very slow. It took several days to observe any effect. And also, only the higher concentration, actually 16 to 32 times the MIC, produced any effect on the Mycobacterium abscessus, which was not a very high effect. When we moved into the hollow fiber model, we observed that the effect was actually lower than the observed in the static assay. We barely hold the bacteria with the highest exposure. Pretty much we didn't kill any bacteria. And that was also with the higher exposures that we tested. Based on this model, we detected that the maximum effect was obtained with 3.2 of the peak of the concentration of the antibiotic under the MIC. But based on simulation, that exposure will not be achieved by many patients. Actually, less than 21% of patients that are treated with the standard amikacin IV dose are not going to reach that target. So the current intravenous amikacin, as we are using for Mycobacterium abscessus pulmonary disease, is not getting the effect that we are looking for. Then we also work with clofazimine that was already mentioned for Jaco in the treatment of MAC disease. And from our experiments, we can conclude that clofazimine has a potential role as part of a combination therapy against Mycobacterium abscessus pulmonary disease. What we did was a synergy experiment exposing the Mycobacterium abscessus both to amikacin and clofazimine and clarithromycin and clofazimine. Initially, we observed antagonism, but after some time, we observed actually synergy. Even that modest synergy prevented the regrowth or resistance that was observed when we used either amikacin alone or clarithromycin alone. Therefore, we consider that there's a potential role for clofazimine in this Mycobacterium abscessus pulmonary disease treatment. Then we moved to another drug that is becoming famous, and it's tigecycline. And for the first time in all the experiments that we performed with the hollow fiber, we detected a bactericidal effect against Mycobacterium abscessus. Based on that, we considered that it should be part of a new combination regimen to be tested. Here you can see a real hollow fiber experiment working, and when we exposed Mycobacterium abscessus to different concentrations of tigecycline, we observed that the effect was bactericidal, and it was maximum at 7 days. After that time, we observed some regrowth, not associated with resistance, at least for the preliminary analysis we performed. We also detected that the EC80 for that was an exposure of the area under the time concentration curve under MIC of 3665. And according to the simulation, more than 90% of the patients will achieve that target if we use the 200 milligrams per day dose. However, that is a very high dose. We know that there are several issues to consider when thinking on that, but this is one of the results that should be taken into consideration for the future design of a new regimen. And the last conclusion from our experiments is that beta-lactam antibiotics are likely to be the driving force in the currently recommended treatment for Mycobacterium abscessus. In my first slide, I mentioned that based on the current guidelines, the treatment for the different species in general is cefoxitin or imipenem, plus amikacin and clarithromycin. What we did was to mimic that regimen in a hollow fiber system model. And as you can see here, it worked pretty well during the first 14 days. After that time, there was regrowth. That was a failure of the system, of the experiment itself. And that was associated, as you see here, with the increasing in the subpopulation that was resistant to cefoxitin. Therefore, we concluded that the beta-lactam, in this case cefoxitin, was the driving force for that antibiotic treatment. And we should consider this for future regimen regime designed to. So for the future, what is like the direction we are thinking or we consider that should be taken into account? Well, we believe that there's a role for clofazimine for sure. We believe there's a role for tigecycline, and the beta-lactam, I don't say a name exactly, but we can think on cefoxitin, or as Jordan mentioned, ceftazidime with or without a beta-lactamase inhibitor can play a role. And also amikacin, as Jacob mentioned, the liposomal form of the amikacin, not the IV, that's the one that we are using right now. And bedaquiline, perhaps, since there's synergistic interaction already reported for bedaquiline with other antibiotics. But again, there's a huge need for new drugs and for a new determination of how is the interaction between all those drugs for considering that in a new regime. Also, we need to extend the evaluation to clinical isolates. Most of the work that have been performed for Mycobacterium abscessus is based on the type strain, but we need to include clinical isolates. Mycobacterium abscessus, it's actually a 3-species complex, and there's, of course, a lot of variation within that. Also, it will be good to include antibiotic with a broader distribution. We know that this is a long disease and there are several compartments. The complexity of the disease itself demands antibiotics with a broader distribution, and also with effect even in the presence of mucus. We know for sure that this is part of the disease itself, and any antibiotic needs to be stable enough in the presence of mucus to be able to produce any effect. Also, the lung is a real hard environment, so the stress models that can mimic the real stressful environment that is present in lung, intracellular models, all of our experiments were performed in the extracellular design, but also we need to consider this, which is actually pretty hard to get for Mycobacterium abscessus, and biofilm, because it was not also part of our evaluation, but Mycobacterium abscessus and several mycobacteria are very able to produce biofilms, and that changes the whole picture and the whole treatment. And of course, as the question that was already, we really need to define and validate susceptibility breakpoints. That's, of course, another area of a lot of interest. And we need to timely detect the drug resistance. You saw already that Mycobacterium abscessus is particularly very, very resistant and can produce resistance very easily after any treatment. And of course, this and all the other conclusions that we have come up are targeting to shorten and to improve the treatment regime, which is particularly a need for Mycobacterium abscessus. Thank you very much.
Thank you very much. You have very impressive work. I think we do have time for 2 questions, and I think we have 2 candidates. So there's a good match there.
Thank you very much. We don't start treatment before drug susceptibility test. What do you think? Another question. There is a new paper, rifampicin is effective in abscessus cases. What do you think?
I'm sorry, if I understood, you're asking about rifabutin?
Yes. What do you think about rifampicin? Rifampicin, yes.
Yeah.
Rifampicin.
Yes, yes. We haven't tested that in our models, but I know that there was a recent paper talking about the potential use of rifabutin against Mycobacterium abscessus.
Thank you. First question, what do you think? First question, we don't start treatment before drug susceptibility test. What do you think? DST, before DST, we don't start treatment.
Yeah, you don't start treatment unless you have run that.
Yeah.
Yeah, but again, I think this is the same answer that Jaco. I mean, we have a standard methods to perform the drug susceptibility testing for mycobacteria, for non-tuberculous mycobacteria. But the thing is, the breakpoint. I mean, we need to validate, to clinically and epidemiologically validate those breakpoints that are suggested for other bacteria, in this case for Mycobacterium abscessus as well. And as far as I know, there's no validation and no breakpoint for rifabutin or many other antibiotics against Mycobacterium abscessus.
Thank you.
My question is about, thank you for the presentation. My question is about the duration of the treatment. And the second part, does it related with the conversion of culture, or without looking after conversion of culture, can we make a duration? Thank you.
Well, the duration of treatment, I think, can vary because it will depend on the clinical response. But as far as I know, it can be as long as 18 to 24 months as like usually is performed. And about the conversion, I think there's a huge need to describe which are the real biomarkers that we are going to use to predict like the cultural convention. Is it going to be the real marker that we need to follow in terms of Mycobacterium abscessus pulmonary disease? I'm not sure. I think there's a paper that is coming in the next months or something that is trying to harmonize experts' opinion on which are going to be the best biomarkers to consider that the treatment is working or not on Mycobacterium abscessus. Perhaps Jaco can...
Well, and as per the current guidelines, treatment is supposed to last for 12 months beyond culture conversion, based on no evidence whatsoever. It's a gut feeling based decision, and you're absolutely right. The duration of treatment is something that really requires good quality clinical studies, because it's a very important field that we all struggle with. You're absolutely right. It's an important question.
Okay, thank you.
Okay. Well, thank you again. Thank you very much. I hope you can hear me. If not, I'll yell a little harder. Wonderful. So thank you very much for coming, and thank you very much for inviting me to come over to speak about NTM disease. And it's interesting that there are sessions about NTM disease, right, in what is the International Union for Tuberculosis and Lung Disease. And I think that's testament to the fact that these infections are important, and that many people active in TB will see these, and they will have to act. And I think, as was just said, we haven't acted for a long time. And sadly, that's also what I want to start with, because 2 weeks ago, one of the founding fathers of mycobacteriology, clinical mycobacteriology, at least in the Netherlands, passed away, my dear friend Adriaan Manten, who with people like Gardner Middlebrook was at the basis of developing the principles of multi-drug therapies for mycobacterial disease, mycobacteriology as a clinical field, and also, he was the first person who described NTM disease in the Netherlands. And mind you, this is 1953. He described Mycobacterium kansasii in the Netherlands before it was called kansasii by people from a not-to-be-named country. So, let's talk MAC and the European MAC experience, because you'll hear from everyone talking about NTM that, you know, NTM disease is emerging. And the interesting thing about MAC is that there's actually sort of two epidemics at the same time. One of them is MAC itself, and the other one, sadly, is COPD, which, at least in the Netherlands, is an important driver of the prevalence of MAC pulmonary disease. Now, MAC pulmonary disease is not a single disease entity. It's in fact two quite distinct diseases, although mixed types do occur. One is the fibrocavitary disease, which radiologically, clinically, microbiologically is a lot like pulmonary tuberculosis. And the other one is a nodular bronchiectatic disease. Both diseases affect a very different patient population. Fibrocavitary disease is clearly linked to underlying pulmonary disease, COPD, silicosis, prior TB. And it's a multibacillary infection. I mean, from a microbiologist standpoint, that's where I am, this is an easy one to diagnose. These patients are often smear positive. You know, your cultures are positive within the week. Easy to diagnose. But as I'll get to, hard to treat. Now, the nodular bronchiectatic disease is a tougher one to diagnose. I mean, if you don't do CTs, you'll probably not even know that your patient who has this prolonged cough and fatigue actually has nodular bronchiectatic disease. Your plain chest x-ray might show some scarring in the midfields, and that might not prompt you to request mycobacterial cultures. Yet, if you do CTs and you'll see this, I hope from now on you will link that to mycobacteria and request mycobacterial culture, and then what? This is a pouchy bacillary disease. Many of these patients are smear negative. If you do 5 cultures, 1 or 2 might turn positive, and the other ones might remain negative. In many patients, you might not even have sputum production, and you'll need to go for a BAL to find that first positive culture that will then tell you, wait, this might be nodular bronchiectatic MAC disease. And the interesting thing is, and that's what we're seeing in the Netherlands as well, that is the epidemic. Because we've become accustomed to using more CT scans, being more aggressive, doing BALs in patients where we think this might be happening. So that's why now, half of the patients attending our clinic actually have nodular bronchiectatic disease, whereas it used to be a tiny fraction just 10 years ago. So the treatment regimen for MAC pulmonary disease is sort of half stolen from TB and half turned out, it turned up by accident when the macrolides appeared to work. So what have we done? We've taken half the TB regimen, rifampin and ethambutol, based on pioneering work by some people actually in the audience, and added macrolides to them, because macrolides work in the lab. Well, and this 3-drug combination works in patients. If you drop one of the 3, it will no longer work. You need all 3 to protect your macrolide, because otherwise macrolide resistance will develop. Surgery remains very important, especially in fibrocavitary disease, but also in severe nodular bronchiectatic disease. And of course, since a lot of these patients have underlying diseases, you need to optimize treatment of their underlying disease to have a chance of curing them. Now, Sanne Zweipfenning in our clinic has done an interesting cohort study looking back at a cohort of patients that we've seen over the past 6 years. And she looked at patients with MAC pulmonary disease. And the interesting thing is, it was still a lot of patients with COPD, but all of a sudden, and you can see that in our clinic, it's women. It's women with COPD on the one hand, leading to the further emergence of fibrocavitary MAC disease, and it is the elderly women with nodular bronchiectatic disease. So a lot more women, a lot more MAC, but they are 2 different diseases emerging. So we are now almost 50-50 in terms of fibrocavitary versus nodular bronchiectatic disease, which used to be 4-1. And sadly, the outcome data showed exactly what, well, of course, we knew from clinic and what we know from critical appraisal of the literature, is that the patients you treat for fibrocavitary MAC pulmonary disease do terrible. We've looked at long-term outcomes, and you can see culture conversion rates are just over 50%. Now, I must say, we are a reference clinic. We treat the worst of the worst. But this is what happens in real life. Culture conversion rates, 50%, up there with MDR and XDR TB. For nodular bronchiectatic disease, those rates are better, which has also been published by others, particularly from the US. But for both groups, there's a massive recurrence rate. Recurrence rates up to 30-40% are the norm. And in the fibrocavitary disease, that's mostly relapse. But in the patients with nodular bronchiectatic disease, a lot of that is reinfection. You cure one episode, they acquire the next, and you're back at 0, and you can start all over. And of course, you can imagine adverse events of treatment in patients who have 4 or 5 comorbid conditions for which they also receive drug treatment is a big, big deal, and drug-drug interactions are rife. So they are very different diseases, and they have very different problems. So fibrocavitary MAC, I think that's where we really need to look for new drugs, because it's a disease you cannot eradicate with the current antibiotic regimens that we use, which, as I said, are based on very, very little. Now, for nodular bronchiectatic MAC pulmonary disease, outcomes of antibiotic treatment, if you look at the very short term, may seem to be better. But reinfections are a big, big deal, and that's a field where we might have to think about secondary prophylaxis and what drugs to use for that. So it's an entirely different problem that's being raised there. And well, then I think the issue of adverse events and drug-drug interactions is really, really tough. And for this reason, we are actively looking for regimens that we can use that do not have rifamycins in there because of all the interactions. But you're kind of hard-pressed to find an alternative. So there is actually a lot of stuff happening, including pharmaceutical company-driven clinical trials. You might be aware that there's trials ongoing and top-line results have been reported on a liposomal amikacin for inhalation. We are doing a clinical trial looking at a clofazimine-based regimen as opposed to the classic rifampicin-driven regimen for MAC pulmonary disease. There's a clofazimine monotherapy trial ongoing for very early disease. And there's a study in France looking at whether it's beneficial to have azithromycin or clarithromycin within the rifampin-ethambutol regimen. So, as was mentioned, my lab also works on preclinical models, trying to find new drugs or new combinations that might become interesting backbones for MAC therapy. Of course, as many people, particularly at this conference, we have an interest in bedaquiline. And I'll tell it to you straight, it's a sad drug. It doesn't do a lot of good for MAC. It's not a good drug for MAC, but you can somehow empower it if you combine it with clofazimine, and that two-drug combination might be of interest as a potential backbone for therapy. We're currently looking at minocycline, which might have some activity against MAC that we can actually use in clinical practice, and you might know that that's a drug that has a very good safety profile. It's oral, and, well, something that we are quite enthusiastic about for the future. But the best thing that happened was that there was a supplement recently published with the Journal of Antimicrobial Chemotherapy by the group that I would say is almost completely here from Dallas, who have looked at hollow fiber model simulations of various new treatment options for Mycobacterium avium complex, who have found very interesting things, like a rapid bactericidal activity of moxifloxacin and thioridazine, an antipsychotic drug, which might be interesting for a sort of an intensive phase style treatment. Tedizolid, which proved to be quite active against Mycobacterium avium complex, and I think we're all eagerly awaiting the long-term safety data of tedizolid to see whether it's relevant to TB and to NTM treatment. And they've even looked at a radical new regimen of tedizolid with moxifloxacin and rifabutin and ceftazidime avibactam. And that proved, I mean, it's a huge regimen, including IV drugs and all, but it's an entirely new concept, and it proved to be as active in the hollow fiber model as the current treatment regimen. And I think that offers a lot of new inroads to think about new treatment options. And perhaps one day we will get back to beta-lactam antibiotics for mycobacterial diseases. So, to conclude, MAC pulmonary disease is out there, so even if you think you work in a TB clinic, it will happen to you, and you will have to act. It's really difficult to treat, particularly the fibrocavitary disease, with its poor culture conversion rates. Recurrences are rife. You'll get to know your patient really well. They'll stick with you for years and years, and we really need to move forward to find new regimens that have early bactericidal activity, if possible, so we can finally think about shortening treatment, and hopefully find a drug that has true sterilizing capacity so there will be less relapse. So with that, I am done. Thank you.
Questions? Please step up to the... And people can just queue up so that when he's done, you can ask your...
Thank you very much. Excellent presentation. I am from Istanbul. I am from Istanbul Medical Faculty. Our treatment results are also same. Our patient is dying now. So I think we must advocate this issue. I can only say this. Yes. Thank you very much.
Thank you.
Go ahead.
Aside from age and gender, are there any other characteristics of the host that have been associated with developing one or the other disease?
That's a very good question. I mean, so are there predicting factors that determine whether someone will develop nodular bronchiectatic disease versus fibrocavitary disease, for example? Yes, there are. And actually, the nodular bronchiectatic disease is often happening in patients who have a very complex sort of, well, you could call it a multi-system disorder. And if you see these patients, it will become clear to you. They often have a different physical type. Their habitat is just different. And a lot of these patients have overlapping conditions, including bronchiectasis, but also connective tissue disorders, like sort of Marfan's disease-like characteristics. And a lot of these diseases have overlapping spectra, and the NTM fit in there. And there's a fantastic paper by a group from the NIH, led by Ken Olivier, who have looked into that, finding gene mutations in genes relevant to connective tissue disease, and yet they predispose to NTM pulmonary disease. So the nodular bronchiectatic disease is really a multi-gene, multi-system disorder of which the NTM is a mere symptom. It's sort of a complication of an underlying disorder. And for fibrocavitary disease, it's usually a more straightforward single diagnosis of COPD, silicosis, prior TB. So that's roughly it.
Thank you.
You're welcome.
So we'll take 2 more questions.
Thanks, that was a fascinating presentation. I'm interested because we often do rely on aminoglycosides for the very severe patients. Have there been or are there any ongoing trials of inhaled aminoglycosides for MAC?
I couldn't really hear that. So do you mean what is the exact role of aminoglycosides for MAC?
Any ongoing
No.
trials?
Have there been any trials of inhaled aminoglycosides? So for instance, in cystic fibrosis, obviously that's quite commonly used, isn't it? So I'm wondering whether in these patients that could be beneficial.
So there's a clinical trial ongoing of liposomal amikacin in MAC, pulmonary disease, in patients who have failed prior treatments. They just released their top-line results, and they actually look very good. So they see significantly increased rates of culture conversion in patients who have that added to their existing regimen. There has been one trial looking at both MAC and abscesses mixed, where MAC did a lot better than abscesses, and the rest is a case series of patients who have used conventional amikacin by inhalation, but they've never shown to have a really positive effect on treatment outcomes. But the liposomal one is showing good results.
Thank you for your presentation. I am from Turkey, Ankara. But my question is about the DST of these drugs for this regimen, because sometimes our clinicians abroad in the country, in other provinces, begin without using any DST. We have DST and we use it, but we are not sure about if it affects or not. So how can we be sure about DST?
Yeah, that's the million-dollar question, and we can spend, well, I would say the rest of the day discussing that. There's a lot of myths about DST for non-tuberculous Mycobacterium. The biggest myth, and you can find that in all your TB textbooks, is that it doesn't work and it doesn't predict treatment outcomes. Now that is nonsense. DST is a perfect predictor of treatment outcomes for macrolides, for amikacin, but also for rifampin and ethambutol, because it shows that those two drugs, rifampin and ethambutol, don't work. And we know that from the British Thoracic Society trials. If you give patients just rifampin and ethambutol, culture conversion rates are 25%, which is equal to not giving treatment at all. And in the lab, those drugs are inactive. You only give them because the combination of the two prevents macrolide resistance from emerging in the patient. So DST, yes, it is very important, but you should only report the results for macrolides and for aminoglycosides. And don't worry about reporting anything on rifampin and ethambutol, because it's not worth it. It will only cast a lot of doubt. The MICs will be very high, and knowing that will not help clinicians. So the current guidelines by CLSI from the US actually mention that you should not report on the classic anti-TB drugs. Just report on macrolides, amikacin, well, and then they say report on moxifloxacin and linezolid. That's it. That's a great question, a very complicated field.
So thank you very much. We are going to get an introduction from Dr. Jotam Pasipanola, who will do the introduction, and then we'll introduce each speaker as we go through. Jotam is an interesting person who does a lot of modeling work, meta-analysis, use of artificial intelligence algorithms, but has a rather colorful life. I came up as a district medical officer to a provincial officer in Zimbabwe, in charge of epidemiology, and then TB, and then after medical school, and then went to Italy for further training, and then to the US for his PhD, and then stayed in Texas. He is going to give us the introduction. He's also at Baylor in Dallas, Texas. Jotam.
Thank you, Professor Gumbo and Professor Van Ingen for inviting me to come and give my talk. And I also want to thank you for for attending this rather peculiar session where we'll be talking about other mycobacteria that are not really tuberculosis. So, I'll be talking about 3 or 4 of those mycobacteria, but just no. Excuse me, sorry. I'm sorry about that. So, so I will be speaking about outcomes of patients that were treated for Mycobacterium avium, Mycobacterium bovis, and of course Mycobacterium abscesses complex in patients who had pulmonary disease. So I don't have any conflicts to give. And the outline on my talk is I'll start talking about Mycobacterium abscesses, then avium, then bovis, and then I'll have a few recommendations that I have to give based on the evidence that I'm going to give. So in our lab, our laboratory, we look at the pharmacology of drugs that are used to treat in various infectious diseases. And, and most of our work has been in tuberculosis. And one of the things that we have seen is that the MIC of each drug really drives the outcome in patients. And with regards to Mycobacterium abscesses, we already know that there are 3 subspecies. So these are different drugs. And we wanted to look at the outcomes of patients that were treated for this. Then we also know that it is the PK variability in patients which also drives outcomes. That is, the concentration time profiles attained in each patient is really different. Each patient has his own concentration time profile, and this has really not been done for some of these mycobacterial diseases. And of course, we know that these pathogens give different lesions. The pathogenesis in different body sites are really different. And what we are interested in defining outcome is to make sure that the drug concentrations are actually attained in these lesions. And but what we already know about Mycobacterium non-TMs is that the same combination of regimens and doses that are used in pulmonary TB have really been directly translated as they are to some of these mycobacterial diseases. And even though some of these diseases are completely are different pathogens, and they even have different subspecies, it was just surprising that we said, why should the regimen used for pulmonary tuberculosis be used for some of these pathogens? So what we did a systemic review and meta-analysis to look at outcomes in patients treated for pulmonary Mycobacterium abscesses. And what we did, our interest was we used the approach that has been the approach that is used because most of these studies that have informed the treatment of these are not randomized control trials. They are mainly arbitrarily prospective studies. So we looked for ways of evaluating the quality of those studies and use the grade criteria for looking at those evidence. So this is the PRISMA diagram where we looked at about 19 studies that were used for treating pulmonary abscesses. So this is the score. We use the iRobin score to look at the quality of each studies, and this heat map is our attempt to look at what was the quality of these 19 studies. And as you can see, a blue shows when there's very little bias on the 7 criteria that are used for this for the iRobin tool that we used. And as you can see, there's very little blue showing. There's very little blue showing when we evaluate for that criteria, meaning that there's a little bit of bias in these studies, and most of these studies actually were not funded by NIH or big government. Most of these studies were funded by institutions without little financial support. So even though these studies are of not much big quality, it shows on the effort of the players that have actually been working at this. So this is the first slide there. It's a forest plot of outcomes in macrolide containing regimens, and I just want to draw your attention to So I just want to draw attention to this number. So when you pull all these 19 studies together and you grade them by the different species, you will see the overall is that the outcomes are very poor. More than only slightly half are able to convert their sputum. But there's also a big difference depending on the species that you are looking at. And you can see here Mycobacterium abscesses is a very poor outcome. Only a third of the patients have sustained sputum conversion, while Myceliensis, actually they tend to do very well. 4 out of 5 of those have poor outcome. And then in some of the studies where they didn't actually give us whether they looked at the different species, you can see that they are in between this pooled outcome. So we also looked at patients that were treated for relapse or recurrent disease, because recurrence is very common in this disease. And again, you can see that the outcomes are even worse. Only 1 in 5 of patients do well when you put the figures together. But when you look at the different species, you can see that for abscesses is also poor, and for Myceliensis, they all have poor outcomes. And it's because in some of these cases, patients tend to have mixed infections. So then in this case, we were just adjusting for the difference in follow-up. When you adjust for the follow-up period, you also still see that the outcomes in the current disease are also poor. So the last step for pulmonary abscesses is we wanted to look if there was publication bias, because like I said before, most of these studies are not really funded by big donors, but when you look for you will see that there is very little publication bias, and you can actually follow up these studies. It's published in AAC, and you can read it in detail for yourself. So the next thing was we looked at pulmonary mark. I'm not going to go into detail here because Dr. Deshpande is going to talk about this, but I want to point you to those figures here that show you that even for initial macrolide containing regimen, and even when the outcomes are also equally very poor, and in those with recurrent disease, the outcomes are also very poor, just about close to 50%. But what I want to draw your attention to this quadrant here, in this cartoon, what we are showing is that what happens when you adjust for the therapy duration. We really don't know for how long we are supposed to treat these patients. So sometimes clinicians just keep on adding months, and you can see that, So you can see that there was not really much gain in terms of the probability that got cured when you prolonged treatment beyond the standard 12 months. In any case, patients start failing, which is really what we know because of the high relapse rate with this disease. And you can see that, of course, there's difference based on the quality of each study. So next, I'm going to briefly talk about Mycobacterium bovis. It's one of the diseases that is really not looked at. Not much studies have been done, and there's a concern that there's an increase in prevalence of both pulmonary and non-pulmonary Mycobacterium bovis. And in one recent study, the large vaccine study, we looked at those children in those 2,000 studies that were had vaccine for TB done, and almost a third of those that had confirmed a mycobacterial infections, a third of those were Mycobacterium other than tuberculosis. So the disease is actually highly prevalent, and it varies between regions. But I would want to point to you that we now know that there is a lot of animal to animal and animal to human transmission of this disease, which has actually been supported by whole genome sequencing data. So what we did, we looked at And of course, this is what I was talking, that the lesions that you see with M. bovis and MTB are completely different, and we know M. bovis is more of a primary progressive disease, while the problem that we have TB is mainly a cavitary disease. So you tend to have different kinds of lesions with these diseases. And then we did a meta-analysis of children that had BCGiosis, the lymphatic form of this disease, and we're looking at the different treatment that were done. And there was one study that looked at just only a needle aspiration, and then another they looked at different antibiotics that were given. And there was really no difference between those forms of treatment that are currently used. So it's another area where we really need to come up with a regimen that specifically targets Mycobacterium bovis. So yeah, I'm almost done. And then we also looked at outcomes in the US of patients that were treated for pulmonary M. bovis, and of course we compared them with those that had M. tuberculosis. This is in the United States, and you can see that in terms of outcomes, they are really not much different when you look at the different proportions. Which means that in the US, in terms of outcomes, M. bovis is equally as bad as M. tuberculosis, and we really don't know whether we are giving the correct regimen for it. So the question that I wanted to highlight is that the outcomes in some of these non-tuberculous Mycobacterium are poor. And with our best regimens, like the macrolide-containing regimens, we really somewhere around 50%, depending on the species that we are looking at. And the regimens that we have been using, and they have been borrowed from another pathogen that is completely different. And we have been trying to build ad hoc regimens to improve outcomes, which is really not the correct way to do it. Dr. Deshpande published a supplement in CID where she laid out steps of developing new regimens for children. And in that, we looked at different drugs. So there is a logic to building this regimen. And we also need to do that for all these other Mycobacterium, non-tuberculous Mycobacterium. And maybe it's some of the other drugs like Ceftas, Linezolid, and all some of these drugs which we have never really paid attention might actually surprise us and might actually give the regimen that would work. But we have to look, and we have to do it in a smart way, not just plucking drugs from there and picking a dose from thin air and start treating patients. I don't think we will be doing a justice to our patients. So I would want to thank the speakers, and sorry for for rushing this through. And these are the people that in our lab that do this work. We just sit behind the computer. Thank you. I will take questions.
Yes, so we'll take about 3 questions. Any questions? Yeah. Over there. Thank you.
Yeah, it's more like a comment than a question, just so that we all agree that Mycobacterium bovis is not a non-tuberculosis Mycobacteria. It's part of the tuberculosis complex. And BCG is not exactly bovis. It's a different disease, complication of the vaccination, and the treatment using antibiotics is there's a controversy since years. So, but I think that this needs to be underlined. I mean, there are really different diseases and different problems.
Yes, thank you. And in fact, that's the comment that we have been saying, that we want to look at these entities as different. It's no use calling a lion a non-elephant. We really need to look at each of these pathogens as separate and treat them accordingly. Thank you.
So, and I wanted to, I think it's a disservice we have done that's been based on us not having enough data, right? So we put all these non-tuberculous mycobacteria into one category. And yes, microbiologically, M. bovis is part of the MTB complex, but there's a difference in the way it's treated. So I think we would never say in Staph aureus all gram-positive, oh, this is treatment from gram-positive cocci, which are all different. It's always puzzling to me why we use non-tuberculous mycobacteria. M. abscessus is not the same as Mycobacterium avium. It's not the same as the others. So to extend your point, yes, I think we should look at them individually, even M. bovis, not so much rely on its relationship to tuberculosis, but design regimens for it sui generis.
Sorry, so Jotam, I'm interested to know, what was the median duration of those regimens that you were showing for abscesses, for instance, and what was the kind of the range?
Right, so they all range between from 12, 15 months to about 24 months. So in each, like on that plot.
And these were mostly observational studies and case series, right?
No, for abscesses?
Yes.
It was between 15 and almost 24 months. Yeah.
Okay. Yeah. Thank you. Yeah.
And I think Beatrice is also going to talk about what we found. They didn't do any good.
Okay. So before I introduce, Dr. Davis' question is, it's all the studies, when you look at them, it's a hodgepodge of observational studies poorly put together. There's really no good data. I'm going to introduce my co-chair here, Dr. Jacob van Engen from the Netherlands, who has done a lot of PKPD work in patients and actually also in vitro in the lab in non-tuberculous mycobacteria, especially Mycobacterium avium. So he's going to speak, and then he will also chair a little bit later.